Hello, my name is Matty Abney, and I'm here with Jordan Flieger, and we will be discussing the comparative effectiveness of antipsychotic medication and cognitive behavioral therapy for psychosis, or CBTP, in the treatment of schizophrenia and first episode psychosis. Schizophrenia is a severe psychiatric disorder characterized by impairments in perception, cognition, and behavior, often referred to as psychosis. Symptoms are broadly divided into positive and negative symptoms, with the current standards of care prioritizing the initiation of antipsychotic medication at the first signs of positive symptoms. Second-generation antipsychotics are generally preferred due to fewer side effects. However, there are still significant side effects. In addition to pharmacological intervention, the APA recommends CBTP as part of comprehensive psychosis treatment. Importantly, it is not to eliminate psychotic symptoms, but rather to reduce distress, improve coping strategies, and enhance daily functioning. Meta-analyses support CBTP across multiple domains, including positive symptoms, functional outcomes, prodromal stages, and comorbid conditions. The effect sizes tend to be small to moderate, typically ranging from 0.35 to 0.44, with better outcomes seen in individuals with greater insight, cognitive flexibility, and shorter illness duration. Despite these findings, two significant gaps remain. There is limited research directly comparing antipsychotics alone, CBTP alone, and the combined treatment, as well as it is unclear how well CBTP is being implemented in clinical practice.
So we performed a literature search of peer-reviewed studies published between 2006 and 2026, drawing from APA PsycInfo, Google Scholar, and Wright State University Library databases. Key search terms included CBTP, antipsychotics, psychosis, and schizophrenia. So one study we found that achieved adequate statistical power in comparing CBTP alone, antipsychotic use alone, and combined treatment of CBTP and antipsychotics was Morrison et al. 2026, published very recently. This investigation used a pooled individual participant data analysis from two randomized controlled trials comparing these three treatment groups. Their sample included 136 treatment-naive adolescents and adults with first episode psychosis. And our present poster focuses specifically on the baseline and 6-month outcomes on the Positive and Negative Syndrome Scale, or PANSS, as a measure of symptom severity. After synthesizing this study, we also connected it to additional studies on themes including the efficacy of adjunctive CBT for psychosis, clinician attitudes towards CBTP, and the current state of clinician training and implementation of CBTP.
At baseline, all three groups demonstrated similar levels of symptom severity. By 6 months, all groups showed improvement. However, the largest reduction in PANSS scores occurred in the combined CBTP plus antipsychotics groups. Between-group comparisons revealed that combined treatment produced significantly greater symptom reduction than antipsychotics alone. CBTP alone did not significantly outperform antipsychotic-only treatment, and the only statistically significant difference observed was between the antipsychotic-only group and the combined treatment group. Overall, these findings suggest that CBTP plus antipsychotic medication is the most effective approach for improving symptom severity in first episode psychosis.
So Morrison and colleagues concluded that CBTP and antipsychotic monotherapies produce comparable improvements in symptom severity, which aligns with prior literature that compares CBT and medication in schizophrenia. But importantly, this study also stipulated that combining CBTP with antipsychotics yields the strongest outcomes. This supports existing research that supports the additive effect of CBTP, particularly for positive symptoms such as delusions. Despite this evidence, CBTP remains significantly underutilized and undertrained. Internationally, only about 23% of individuals experiencing psychosis are offered CBTP, and in North America, fewer than 1% of mental health professionals have received formal CBTP training within the past 15 years. Even when CBTP training is available, it is often time-limited, which may not be sufficient for effective clinical implementation. Additionally, mixed findings regarding CBTP's effects on negative symptoms and long-term outcomes may contribute to clinician skepticism, with only about 40% of U.S. psychologists believing in the efficacy of CBTP.
In conclusion, Morrison et al. Strengthens the evidence supporting integrated treatment for psychosis. While CBTP alone is not superior to antipsychotic medication alone, CBTP provides an additive benefit when combined with pharmacological therapy, particularly for positive symptom reduction. Although questions remain about its effects on negative symptoms, long-term relapse prevention, these uncertainties should not delay implementation, especially given the limited side effect burden of CBTP. The persistent gap between research and clinical practice highlights a pressing need for expanded training, improved dissemination, and further investigation into how CBTP can be optimized, particularly for negative symptoms. Future research should focus on standardization of CBTP training, infrastructure, and systemic barriers to ensure that evidence-based psychological treatments are accessible to individuals experiencing psychosis. Thank you for your time. Hello, my name is Matty Abney, and I'm here with